Good afternoon, everyone. So what I'm going to talk about in the next half hour or so is where we are with genetic testing and hereditary GI cancers in 2024. So what I'd like to do is really share with you some of the key hereditary GI cancer syndromes that you should be aware of. And we're going to focus primarily on colon cancer syndromes and pancreatic cancer syndromes, and then the approach to making the diagnosis through genetic testing. So I do have one disclosure here. So just by way of background, genetic testing in 2024 is now the standard of care for the diagnosis of hereditary cancer syndromes. And I think this is an important message because I think many of us have learned in the past about various clinical criteria that we use to establish a diagnosis. And while these are very important, I think we now rely on many much more objective criteria, and that is a positive gene test. This graph shows that the demand for genetic testing continues to increase over time, and this will continue to go up in the years to come. And the last point I want to make is that while you may initiate genetic testing or refer one of your patients for genetic testing, many patients are seeking out genetic testing on their own. And in fact, there's a lot of direct-to-consumer marketing through companies such as 23andMe that offer not just what we say recreational genetic testing for ancestry type of results, but many of them will actually also test for a variety of hereditary cancer genes as well. And so a patient may come to you to your office with one of these reports, and it'll be important to know how to interpret that. So historically, there are three important trends are important to understand about where we have been and where we're going in terms of genetic testing for hereditary cancer syndromes. So several decades ago, when this field really first started, there were only a few genes that we knew of. And these were the first genes to be cloned, so-called APC gene, MSH2 for Lynch, and the BRCA genes. And steadily over time, as certainly sequencing techniques became faster, cheaper, and more sophisticated, we now recognize that there are many, many genes that are associated with a variety of hereditary syndromes. And right now, there are at least 125 such genes. Now, concurrently, the price for doing such gene testing has fallen dramatically. So initially in 1990, when we first started doing this, it cost over $3,000 to test a single gene. We now can test a whole panel of genes for one low price of about $250. So this certainly has made genetic testing much more accessible, and certainly allows us to test multiple genes at once and not pay per gene. And finally, one of the most important pieces of legislation that passed was the so-called Genetic Information Non-Discrimination Act, or GINA. And this was a response to concerns that genetic information could be used to discriminate against people. And so what this federal law does is protect individuals for discrimination based on genetic test results, both in the workplace as well as for health insurance. Now, what it does not do is protect people for life insurance, and that's one thing that patients who pursue genetic testing should be aware of before they do it. So this is the overview of all of the syndromes, GI cancer syndromes that we see within the field of gastroenterology. As you can see, there are quite a few, and they can be divided into certain categories. And what I've done here is shown, first of all, the colon cancer syndromes, namely the ones that are associated with polyposis. And there are a number of these that are adenomatous polyposis, such as Gardner's FAP, MAP, PPAP, as well as so-called hamartomatous polyposis syndromes, such as Poitzjager, Cowden, juvenile polyposis. There are non-polyposis syndromes, and Lynch syndrome is the prime example of this, and the most common hereditary colon cancer syndrome. There are also now pancreatic cancer syndromes. There are a variety of different genes associated with this, all which behave slightly differently. The one gastric cancer syndrome is one associated with the diffuse types of gastric cancer, so-called signet ring cells and linitis plastica. That's the hereditary diffuse gastric cancer syndrome. Pancreatic neuroendocrine tumors associated with MEN1, and there are hereditary forms of GIST as well. We're not going to talk about all of these, but I wanted to highlight a couple of the important adenomatous polyposis syndromes, Lynch syndrome, and then hereditary pancreatic cancer syndromes. So the reason to understand this is, of course, that these syndromes are actually more common than you think. I think in the past, we used to think that, oh, I'm never going to see these syndromes. They're not that common at all. They actually are much more common for both colorectal cancer as well as pancreatic cancer. And so in CRC, about 75% of all cases are sporadic. About 20% are actually familial, meaning that there is probably some genetic component which we have not yet identified what that gene is. But about 5% of all colon cancers will be associated with an underlying cancer syndrome. For pancreatic cancer, the number is actually even higher. About 80% are sporadic, maybe 5 to 10 fall into this familial category, but up to 10% are associated with an underlying genetic alteration. So recognizing hereditary cancers changes your management. And so this occurs in 3 key ways. So number one, if someone actually has a cancer, it leads to an alteration in the surgical approach. And namely, this means a more extensive operation. So for colon cancer in particular, if someone, for example, has right-sided colon cancer, has Lynch syndrome, the surgical approach would not just to be a right hemicolectomy, but you would actually do more extended subtotal colectomy because of the higher risk of metachronous cancers down the line if you have a hereditary syndrome. One of the most exciting advances has been that the genotype can actually determine eligibility for new targeted therapies, and probably PARP inhibitors represent the most important example of this. So individuals who have a germline BRCA mutation can indeed are candidates for PARP inhibitor therapy. The cancer surveillance is quite different if you have an underlying syndrome. And I think the key message here is not that there is intensive surveillance, not just for the primary cancer, like in a colon cancer syndrome, doesn't just mean more and more frequent colonoscopies, but there actually are high risk of tumors in extracolonic locations as well. And so it would be important to make sure that a plan is put in place to screen for those extracolonic tumors. And finally, there's an increased risk of cancer, obviously, in family members. These are all familial conditions. And so a key part of management is what we call cascade testing, where first-degree relatives should then get screened with genetic testing to find out who has the gene and who does not. Historically, we have not generally done very well on this front, and only about 50% of relatives will pursue genetic testing, meaning leaving many unaware of their risk and probably not being surveyed appropriately. So one final background slide here also on what does it mean when we talk about doing genetic testing. So as I said, genetic testing is the standard of care for diagnosis. And when we're talking about genetic testing, we're talking about analysis of germline DNA. That means germline DNA that's in the white blood cells of every cell in your, they're in white blood cells, but they're also in every cell of your body, but we can assay it through white cells. And you can assay white cells either through blood or in saliva. It turns out there are a lot of white cells that are in the saliva. But what genetic testing is it's not analysis of tumor DNA. So there is a lot of tumor sequencing that can happen. Those usually look for what we call somatic mutations. And it's not what we call analysis of circulating cell-free DNA, which is kind of like one of the biggest new things in terms of managing individuals who have cancer. This is looking at small fragments of DNA that are released from tumor cells and which spread throughout the circulation. So genetic testing does require informed consent. And nowadays, the cost is covered indeed by most insurance payers. But for those for for whom it is not covered, the cost is about $250. Now, I know that's not a trivial cost, but it is certainly much, much lower than the thousands that it used to be years ago. So let's take a look at hereditary colon cancer syndromes. And the best way to think about them or divide them up really, are the polyp count. So is it a polyposis syndrome or is it a non-polyposis syndrome? So the most common non-polyposis syndrome is Lynch syndrome, and we'll talk more in detail about that later, but generally less than 10 cumulative polyps that are seen. So in terms of the polyposis syndromes, we think about those that are either what we call oligopolyposis, meaning 10 to 100, or true classic polyposis, hundreds to thousands. And so classic FAP is the syndrome that we will all know well, that as far as a classic polyposis syndrome. The attenuated version we often see with far fewer polyps. But then there are a variety of other new ones called mutant YH-associated polyposis, polymerase proofreading associated polyposis, and serrated polyposis, which can actually span some of these criteria. So they most often are seen kind of in this oligo range, but can certainly span into the classic polyposis number range as well. So in terms of the adenomatous polyposis syndromes, there's classic FAP, which is inherited in an autosomal dominant way. Hundreds of thousands of adenomatous polyps that typically begin in the teenage years. 100% risk of colon cancer without a colectomy. And the most prominent and important extracolonic tumor is duodenal and ampullary cancer, which can occur in 5 to 12% of individuals. The attenuated version of FAP, as the name implies, means there are fewer adenomas, to 10 to hundreds. They tend to start in adulthood, not in childhood. So in the 30s to 40s, it may become more apparent. The colon cancer risk is still quite high, over 80% if nothing is done. But these individuals also do exhibit duodenal polyposis. The MUTYH-associated polyposis syndrome is another oligopolyposis syndrome that looks a lot like AFAP. However, the key difference is that it's an autosomal recessive condition, so that one needs to inherit a copy from both parents, and only when that individual inherits two copies will the syndrome manifest. Now, serrated polyposis is probably one of the newer ones, and the definition here continues to evolve a little bit, and some of that is because we don't really understand the genetics particularly well yet. But clinically, this one ends up being defined by the presence of 5 or more serrated polyps proximal to the rectum, all of which must be 5 millimeters or larger, and at least 2 of which are 10 millimeters in size. Or you can have more than 20 serrated polyps of any size distributed throughout the colon, with at least 5 or more proximal to the rectum. As I said, we don't fully understand the genetics yet, but there are a couple of genes that have been identified, one of which is RNF43. However, this only accounts for a small minority of individuals with serrated polyposis syndrome. I do want to spend a few minutes on Lynch, because Lynch is far and away the most common and the most important hereditary colon cancer syndrome that you probably will see. In terms of prevalence in the population, one study put the estimate to be as high as every 1 in 280 individuals. And this may be due to a founder effect in Iceland, where this study came from, but I think the point here is that this is indeed a common hereditary cancer syndrome. It is also inherited in an autosomal dominant manner, characterized by colon cancer relatively early in the 40s to 60s, and often multiple primary tumors. There's a high risk of endometrial cancer, which is the other salient cancer phenotype, but there are very, very few adenomas. We know the genes that are involved, and they are all in one of genes involved in the so-called DNA mismatch repair pathway. And we know that Lynch cancers will not express these DNA mismatch repair proteins by immunohistochemistry, and that has become a way now to screen for Lynch syndrome, to do immunohistochemistry for these proteins on a colon cancer sample, and the absence of staining is suggestive of Lynch and should dictate a further genetic workup. Now, I think one of the important things that we learned about Lynch is that all of these genes behave in a very different way. And so it is not a sort of monolithic diagnosis, as we may have learned decades ago, but that it actually matters which gene is present because your cancer risks vary by which gene. And so this shows the 4 primary genes and some of the more common types of tumors that we see. And so, for example, if you look at colorectal, the highest risks are in MSH2 and MH1 up to 50-60%, where they're much lower in MSH6 and PMS2, and they tend to occur at older ages. Endometrial cancer, however, is quite common in MSH2, MLH1, and MSH6 with up to 50% lifetime risk, however, much lower in PMS2. As far as the other extracolonic, extraendometrial cancers, ovary we see primarily in MSH2 and MSH1, and urinary tract primarily in MSH2 carriers, and we're talking here about renal, pelvis, ureter, and potentially bladder. So understanding the gene is important because that will then help you understand what is the right kind of surveillance that you should be recommending for your patients. So when we are concerned about a diagnosis, genetic testing is, the standard of care. And the way we do genetic testing is through so-called multi-gene panels. We don't pick which gene we want individually and say, I'm only going to test Lynch genes, I'm only going to test MSH2, etc. But you can actually test multiple genes, so you can test all the colon cancer genes all at once. And it's helpful because it doesn't rely on that what we call sequential testing, where you test one gene, it's negative, you go test the next gene, it's negative. You can just test them all at once. And as I said, the cost, the technology has really made the cost not an issue anymore. So the question is how you pick which panel that you want to order. And I think that there are 2 main principles to keep in mind when you try to pick a gene panel. So number 1 is the breadth of cancers you want to test for. And number 2 is the strength of the link between the genes and the cancer risk. And let me explain what that means. So when we talk about breadth of cancers, you could decide to say, I'm just going to test cancer genes that are all associated with colon cancer because my patient just has colon cancer, as opposed to saying, well, I'm going to do a multi-cancer panel where I'm going to test all the colon cancer genes, but also breast cancer genes and pancreas cancer genes, just because there may be someone in the family who also has a distant history of breast cancer, or that I just want to know if I might have one of these other genes. And then on the other side is how strong the association is for each of these genes with the cancer risk. So you could pick genes that we say are only very well established. We have good information about what the risks are, how to manage those risks, and those have been dubbed actionable genes. Or you could say, science is changing constantly. There are all these new so-called preliminary evidence genes that are coming out. We can test for those. We may not know quite what they mean or what to do with it, but I want to know. And so you could pick the whole shebang and do everything at once. And so this is the biggest panels will be these so-called up to like 125 genes, or you could pick smaller ones like just a single cancer with only actionable genes on them. And these are all options that are available to you and your patients. Now, I think the important thing when you get a test result back is understanding how to interpret it. And so I think when there's something positive or negative is pretty straightforward. But I think that the one type of result you need to be kind of aware of is something called a variant of uncertain significance. And a VUS is a DNA alteration. It's typically a missense mutation. So that means it just substitutes a protein for a different protein that may or may not be predicted to alter its function. And we interpret this basically as an uninformative result, and that you should not act on it, as being positive or negative. Historically, the vast majority of VUSs do often get reclassified, and over time get reclassified as a benign polymorphism or negative. So that is reassuring, but I think until you actually get that reclassification, you can't tell a patient that it's a negative result. However, some people interpret a variant of uncertain significance as being positive, and that's where people have gotten into trouble. So the interpretation must be handled very carefully. And in fact, there is an example of litigation in which a woman had a VUS found in the MLH1 gene, which is the gene associated with Lynch. And this was incorrectly interpreted as being positive. And so management proceeded as if she had Lynch. She had a hysterectomy. Mastectomy was also performed for other reasons. And ultimately, it was reevaluated, and it became clear that this was just a VUS and not a positive result. And unfortunately, litigation did occur, and the case was ultimately settled. So when we think about who should have genetic testing, there's several categories we think about. So one is you have a patient who has a personal history of multiple polyps, or actually a personal history of colon cancer. So for multiple polyps, we say you should have testing if you have cumulatively 10 or more adenomas, because you may have one of these oligopolyposis syndromes. For colon cancer, the reasons that we generally say anyone should have genetic testing are, number one, there's this abnormal IHC test, as we talked about. That's the screening test for Lynch syndrome, looking at the Lynch syndrome genes. Anyone with young onset colon cancer, some of the literature will say under 50. I personally will do anyone under 60. And then in terms of family history, if they have a colon cancer plus a family history of colon cancer or endometrial in a first-degree relative, I would recommend testing. Or there are now a number of online risk calculators that you can use to sort of amalgamate people's family history and clinical features, and that can give you a risk prediction and tell you if it's high enough that you should go ahead and order genetic testing. Now, one of the questions is, if you are interested in pursuing testing, is, do you just order the colon panel, or do you just do the broad multi-gene panel? And, I think that this is a study that came out a few years ago, kind of just performing multi-gene panel testing on all comers with colon cancer. And this is what they found. So this was over 1,000 individuals. And about 10% had a gene mutation identified. Now, about 3% were Lynch, which is kind of on par with what we'd expect. About 1% had a polyposis or colorectal cancer syndrome. And most of those, manifested polyposis, so that was not a surprise. I guess the main point here is about that there's 1.3% who had an unexpected gene. And so this is like a BRCA gene for breast and ovary cancer. P16 is a melanoma pancreas gene. About 3.6% had a low penetrance gene, CHEK2, and 31% had a VUS. So that's like nearly a third of individuals had one of these VUS findings. So the point here is that you will pick up things. It turns out that of these 3% who had Lynch, probably nearly all of them had family history criteria or abnormal IHC, so you would have picked them at that way. But I think the one thing you gain are these 1.3% who had an unexpected, I would say, actionable gene. So the formal guideline is not that you should offer genetic testing to every colon cancer patient. But I think that the pendulum is swinging, and that the NCCN now recognizes that universal gene testing for all colon cancers is indeed an option, so that even if they're like 70, that it is an option. I wouldn't say it's a strong recommendation, but it is something that is available to you if you and or your patient is interested. Now, the other big category are individuals who come to you of a family history of colon cancer or polyposis. And so the strategy here is, number one, you should try to test the family member who has cancer or polyposis first, because what you want to do is identify what the genetic alteration is in the family. And then if that relative is positive, then you can now test your patient to see if your patient has that same gene or not. Now, if the testing relative is not an option, which unfortunately does occur, either they're not in touch, or the relative's deceased, or they live abroad, you can go ahead and offer your patient testing, and that's a perfectly reasonable option. The one caveat there is that you're doing it without knowing that there is a familial mutation present in the first place. So if your patient comes back positive, then you know that they're positive, and it's likely that that's what runs the family. If they come back negative, I mean, that's reassuring that they don't have one of the genes that you've tested for. But what you don't know is that the relative affected with cancer or polyps was indeed positive. And so in that case, we would say, it's great to know that your patient was negative, but you should manage your patient based on the family history still. Okay. So I'm not going to go in great detail, but I just wanted to just highlight some of the cancer surveillance measures that are employed for Lynch. And I think the key thing is that colonoscopy is very frequent, every 1 to 2 years. And that's because cancers grow very quickly. And you start young, 20 to 25. And you see the guidelines are younger for MLH1 and MSH2, start much older for MSH6 and PMS2. Endometrial biopsies recommended, again, every 1 to 2 years, starting age 30 to 35. And consideration of risk-reducing oophorectomy really is primarily in MLH1 and MSH2 carriers. Upper endoscopy is something we recommend every 2 to 4 years, meaning every other time a patient comes for a colonoscopy. And we start generally somewhere in the age 30 to 40. And finally, urinary tumor screening is really confined primarily to MSH2 carriers. For the FAP and MAP syndromes, we start much younger, obviously. So in FAP, we start, around 10 because of the presentation in kids. Attenuated, you can start later in the teens. MAP is somewhere between age 20 to 25. And of course, these individuals have regular surveillance until you think that they actually may need colectomy. So for the upper GI surveillance, we do focus on the duodenum and the ampulla, and it's important that you do look at the ampulla either with a side viewing scope, or you can do it with a clear cap on the end of a forward viewing scope. So the interval will depend on what you've seen on the prior exam, but can range anywhere between 1 to 5 years. Thyroid nodules and thyroid cancer is more common, and so we do recommend ultrasound starting in the late teens, repeating every 2 to 5 years based on whether nodules are present or not. And I think the other thing to make sure you remember is that once someone has had a colectomy, they still require surveillance of either remaining rectum, pouch, or rectal cuff. And so that should be done on an annual basis as well. In serrated polyposis syndrome, the standard recommendation now is a colonoscopy every 1 to 3 years with clearance of polyps greater than 5 millimeters in size. In the past, we used to be much more aggressive about recommending risk-reducing colectomy, but it turns out that the cancer risk in this syndrome is probably not as high as we originally thought, but it is an option if advanced histologic features are present or polyp number cannot be managed. So just a couple of quick cases to show you some individuals who come to our genetics clinic. This is an individual who had colon cancer at 46, came back later with a small intestinal adenocarcinoma at 56. And when we probed the family history, mother had uterine cancer 65, uncles had colon, and there was a cousin who had a young colon cancer at 58. So what happened? Well, we performed immunohistochemistry in both the colon cancer and the small intestinal cancer, and they showed loss of MSH2, signaling that this is likely Lynch syndrome related to MSH2 germline mutation. So genetic testing was performed and identified a pathogenic variant in MSH2. This is a young individual, 33, who had cecal cancer and about 5 other polyps throughout the colon. So not hundreds, but 5 other ones, and one of which was also malignant. There's no known family history of polyposis or cancer. And so this individual had broad multi-gene panel testing looking, is this Lynch? Is this an oligopolyposis syndrome? He ended up having 2 MUTYH mutations, making the diagnosis of MUTYH associated polyposis, which you recall is an autosomal recessive condition, which was consistent with the family history. So I want to spend a few minutes here now, but with hereditary pancreatic cancer syndromes, because this is one that's getting a lot more interest and attention. Pancreas cancer is rising in incidence in the population in general. And we now know that, as I said, many of these cases are genetic in origin. There are very few actually truly just strict pancreas cancer syndromes. And in fact, most of the syndromes we know of are in established genes that cause other types of cancers, such as Poitzieger's, familial atypical mole and melanoma syndrome, hereditary pancreatitis, Lynch, the BRCA hereditary breast ovarian cancer genes, and the ATM, which are high risk for breast cancer. And so each of these genes and syndromes does have a high increased risk of pancreas cancer as well, anywhere between 2 and up to 130-fold. Now, when we look at all cases of pancreas cancer, it turns out, anyway, as I said before, anywhere between 4 and 10% will have an underlying germline mutation. The key messages here are that the most common genes we see are BRCA2 and ATM. And the other key message is that only about 10% of these cases will have a family history of pancreas cancer. So family history is not particularly reliable for identifying these hereditary cases. So that has led to the recommendation, which is really quite simple, fortunately, that who should have gene testing for hereditary pancreas cancer? Everyone who has a diagnosis of pancreatic cancer. So universal gene testing for everyone who has a diagnosis of pancreatic cancer. And so the other question then is, who needs high-risk pancreas cancer surveillance? And so there are several criteria that we use. And so one of them is if someone meets family history criteria, and this is so-called familial pancreatic cancer, this means either you have 2 first-degree relatives with pancreas cancer, or you have a first-degree relative and a second-degree relative, and that second-degree relative is a first-degree relative of the former. Any patient who has hereditary pancreatitis, because we know that's due to a mutation in the cationic trypsinogen gene, because those individuals will all have a high risk of pancreas cancer. Anyone with Poitzieger syndrome or the FAM syndrome, because we showed those have very high risks of pancreas cancer. But for the other syndromes, BRCA, Lynch, PALB2, ATM, the risks are not so high. And so the current guideline is that if you are a mutation carrier, we would recommend pancreas cancer screening only if there's also a family history of pancreas cancer in a first or second degree relative. And what is that surveillance? It is an annual exam looking at the pancreas, alternating between an MRI, MRCP, and an EUS. You start at age 50 or 10 years younger than the earliest diagnosis in the family. For Poitzieger's, FAM, and hereditary pancreatitis, we generally start younger, anywhere between 35 and 40. So is this effective? I think we're finally beginning to have some data that screening for pancreas cancer in these high-risk individuals can be worthwhile. One of the first studies was published in 2018. This came out of a group at Johns Hopkins, which followed 354 high-risk individuals with EUS, MRI, and CT, and showed that about 19% or 68 developed concerning features in their pancreas, 24 or 70% progressed, and 10% ended up having high-grade dysplasia, and 14 actually developed pancreatic cancer. The mean age of diagnosis was 67 years, and the mean duration from the start of screening to diagnosis was 4.8 years. What I wanted to show you was that there was a follow-up study where they continued to monitor these individuals in this study, and they recently published their data a couple years ago. And what this showed was the probability of survival among those who had had a screen-detected pancreas cancer and among those who had pancreas cancer detected outside of surveillance. And I think the main message here is that the survival you can see here is far greater than for those who had had a screen-detected cancer. And that's due primarily, obviously, to a stage shift, that you have early, lower stage disease and people who are more likely to be operable. And so here's an example in how we apply this in someone who comes to our genetics clinic. So this is a woman who had breast cancer at 44, was found to be BRCA2 positive. She had bilateral mastectomies and said, well, my dad had pancreas cancer at 66. Like, should I get screened? And so we would say generally, yes, she is BRCA2 positive and she has a family history, but I think we wanted to confirm that indeed the BRCA gene tracked with her paternal side. So we tested her mother, and her mother was BRCA negative. So we did indeed confirm that it came from her father's side. So yes, she now is undergoing high-risk pancreas cancer surveillance. All right, so I just want to summarize here with just a few take-home points. So in terms of colorectal hereditary colon cancer, there are many CRC syndromes, but Lynch is the most common. When should you refer for genetic testing? When you see colon cancer in 2 or more family members, when you see colon cancer before age 60, when you see the combination of colon and endometrial cancer, any cancer that has abnormal IHC staining, or if you have more than 10 cumulative adenomatous polyps. For pancreas cancer, all patients with pancreas cancer should be referred for genetic testing. And once you've defined a high-risk individual, then high-risk surveillance should be initiated. So multi-gene panels are now the standard for genetic testing, and there are many different types of options that are available. And finally, just a word of caution that when interpreting these genetic test results, you need to be careful, particularly about variants of uncertain significance. So thank you for your attention, and I look forward to any questions during the question and answer session. Thank you very much.